What role does age, or maybe we don't have the full answers to this right now, but what role does age or disease duration play in the potential for successful remyelination, and how should that inform clinical trial designs going forward? I know obviously in neurology right now, clinical trial designs, the ins and outs, the exclusion and inclusion criteria are very, very much a topic of controversy at times. So talk a little bit about the role that age and disease duration plays and how might this impact future trials going forward?
So I think it's a fantastic question. I think there's a very simple answer, which is we don't know. That's the simplest answer. There's a more nuanced answer, which is that it's almost certain that there are some subsets of patients for whom remyelination will be more potent, and will be easier to measure without lots of competing factors. It touches a little bit on the point being made about the preclinical assessments, because the preclinical assessments, different ones are useful for different purposes. So some of them include inflammation in them and some of them don't. And that's super useful for us to disentangle the effects of inflammation from demyelination. I think loosely, people in the clinical space will sometimes think of demyelination and inflammation as superimposed, as if they're almost the same thing. But in reality, they're different biological effects. And that's important in thinking about measurement. It's important to think about the preclinical models. It's also important in thinking about when and how best people will get remyelinated and who's going to be most amenable to remyelination. One thing we know for certain is that people who lack an underlying axon, if there's no nerve fiber to remyelinate, remyelination is not possible. And there are lots of people who, even though that's seemingly obvious, there are people who undertake and investigate approaches for remyelination just in the wrong clinical context. We're all hopeful for therapies that'll have like a Lazarus effect and bring people out of wheelchairs and enable people who are severely disabled to restore some, if not complete, function. But we also don't want to create the unrealistic expectation that remyelinating therapies are going to miraculously have that effect, especially in the context where axons have been lost. And therefore, it's likely a mistake to investigate first remyelinating therapies in the context of people who have already suffered from severe disability. It may be important, almost in the same way that people in the cancer space in compassionate use utilize some of those therapies for compassionate use people with end stage or advanced cancer. But it may not be the right way for efficiency for the field, and it may not be the right way to optimize the speed with which we develop these therapies for the broadest population of patients or people who are living with MS. So I think we've got to have that, sometimes difficult but nuanced conversation with people. I think when we have it in a way that reflects on all the nuances, people get it. But sometimes, and understandably, all of us who care about people who live with MS want to get the most effective therapies in the space as fast as possible. But we have to recognize that the way to do that might be in effectively showing remyelination in some narrower context so that we can expand it outward with success over time.
I think just to amplify the point, we, as with sort of most regenerative processes, remyelination effectiveness is generally thought to decline with age and prolonged disease duration. The definitive aspect of this in humans and whether or not it can be unlocked or reversed still remains to be seen, but generally thought that OPCs may become less responsive or the CNS environment might be less permissive to remyelination with age, and certainly with disease duration where you have neurodegeneration, the opportunity to remyelinate and protect those axons goes away. And so I think what this means for the implications for clinical trials is really provides strong rationale for earlier therapeutic intervention strategies, right? We know progressive neurodegeneration starts at the very earliest phases of disease and continues even in the absence of relapse activity, even on some of the very potent and effective immunomodulatory therapies. So I think the earlier we can replace lost oligodendrocytes in myelin, I think it's likely to lead to better outcome for patients. But the earlier treatments, come back to the question of biomarkers and imaging modalities, because you're now at a phase of the disease where there's sort of less going on. So the ability to accurately be able to say we've replaced or restored oligodendrocytes, back to quote unquote baseline or normal or improved above the disease state becomes even more challenging.